Let's get started. So the most important thing in treating melanoma is diagnosing melanoma, and that occurs at the time of biopsy as well as at the sentinel lymph node biopsy, and then also reassessing at the time of systemic disease presentation. So melanoma biopsy diagnosis, you've got your simple diagnoses, which includes lesions with architectural atypia and sun-damaged skin in older patients, or severe pleomorphism in any patient. Here's an example of an older patient with sun-damaged skin. You have lentiginous and nested growth with pagetoid spread, easy diagnosis. Here's a younger patient without sun damage, sheet-like growth of melanocytes, pagetoid spread, and epidermal ulceration, easy diagnosis. But in some cases, the diagnosis is difficult, and that's typically in spitzoid lesions in younger or middle-aged patients. Here was a case that we had in a 14-year-old boy on the distal thigh. It's polypoid with epidermal effacement. It has nests of melanocytes that are spindled and epithelioid and intersecting. And it had a lot of mitotic activity in the dermis, including deep dermal mitoses. When we look at the histologic features that can be worrisome in spitzoid lesions for melanoma, we think about asymmetry, lack of circumscription and maturation, ulceration, epidermal consumption and pagetoid spread widely across the breadth of the lesion, deep dermal mitoses, like in this case, frequent mitoses or high-grade atypia. We also think of immunohistochemical features, which I'll get into, and that can include complete P16 loss in the dermis, either complete loss or complete retention of HMB45 in the dermis, and deep and high Ki67 labeling index. So our workup protocol at the Cleveland Clinic in these types of lesions are, if they have worrisome histology, no, it's a Spitz nevus, and patient can go on without any other treatment. If there are worrisome histologic features, at the minimum, it would be an atypical Spitz tumor. So then we do immunohistochemistry. If it's not worrisome, we stop there at atypical Spitz tumor. If it is worrisome, we might go to FISH, which will be discussed later today, fluorescence in situ hybridization. If that's worrisome, you get into spitzoid melanoma. If not, but you're still concerned, you can do genomic hybridization to get to either an atypical Spitz tumor or spitzoid melanoma. So back to our case in the 14-year-old, there was complete dermal retention of HMB45, which we said is worrisome. There was almost complete loss of P16 in the dermis, which is also concerning. And the Ki67 labeling index was somewhat higher than we typically see, maybe around 3%, with also deep dermal mitoses. Now, we did look for ALK, which can reflect an ALK translocation, which is known to occur in atypical Spitz tumors, but it doesn't rule out a progressive melanoma evolving out of an atypical Spitz tumor. And so we were still concerned enough based on the other histologic and immunophenotypic features that we discussed to do FISH. And these are the criteria for FISH. I won't go over them. They'll be discussed later today. But in this case, the patient was negative for mutations typically associated with melanoma. So it was signed out as an atypical Spitz tumor. So just to summarize, worrisome features for melanoma at biopsy are complete loss of P16, complete loss or retention of HMB45, a high and deep Ki67 labeling index, and if any of the above are not reassuring, we go on to molecular testing. So talking about the sentinel lymph node biopsy diagnosis. When do we do sentinel lymph node biopsies for melanoma? So this is the updated AJCC staging criteria for melanoma, the 8th edition, and we can see that T1 tumors, which are less than 1 millimeter, have now been broken into T1A, which is less than 0.8 millimeters without ulceration, and T1B, which is 0.8 to 1 millimeter, or any less than 1 millimeter with ulceration. And because the AJCC 8th edition recommends rounding up to the nearest tenth, what this really translates to is anything that's 0.75 in Breslow thickness and above is going to get a sentinel lymph node biopsy. So how do we process these? We want to totally submit all lymph nodes sent as sentinel lymph nodes. We serially breadloaf the lymph node along the long axis at 2 millimeter intervals. We don't intermix separate sentinel lymph nodes in the same cassette because that will confound determining the correct number of sentinel lymph nodes involved. And each cassette gets an H&E stain, a Melanoma stain, HMB, and SOX10. H&E stain is good for larger disease, but you may miss single cells. Melanoma is a robust stain. It's positive in most melanomas, but it can be negative in desmoplastic melanoma. SOX, or poorly differentiated spindle cell melanomas. SOX10 is a nuclear stain. It'll be positive in all melanomas, but it also stains small nerve twigs and glandular myoepithelial cells. And HMB45 can be positive or negative. If it's positive, that's more worrisome. It's a marker of immaturity in melanocytic lesions, but you need to correlate it with the primary tumor. And so here's an example of H&E evident bulky metastatic disease in a lymph node. You can see here epithelioid pigmented cells interfacing with lymphocytes. Here's an example of IHC only evident. You have a dilated afferent lymphatic, and here you've got sort of melanophages, some activity. You can't really call this melanoma, but when you do the SOX10, there's nuclear positivity with enlarged nuclei corresponding to the same area of melanoma positivity and HMB45 positivity. So that was a minimally involved sentinel lymph node, and that person would be stage 3 by definition. So let's go on to the role of immunohistochemistry in systemic management of melanoma. We know that melanoma treatment historically has been different in most cancer types in the fact that it has almost no response to chemotherapy or radiotherapy, and certainly none of the responses are durable. But there's been a relative success of immunotherapy, including interleukin-2 and interferon alpha-2 beta, which are non-targeted forms of immunotherapy. Adoptive T-cell therapy has a relatively higher response rate, but it's technically difficult to carry off at multiple institutions. And so this is shown here. Previous to 2011, we had dacarbazine, interferon alpha, and interleukin-2 were the only FDA-approved drugs for melanoma. After 2011, we had really an expansion in the types of targeted drugs we can use for melanoma, and those can be broken into genomic targeted drugs and immune targeted drugs, seen here. And when we think about our genomic targeted drugs, they're really reflected in this paper published in Cell, where they took a large number of melanoma, primary and metastatic tumors, and looked at their DNA mutations, copy number changes, whole genome sequencing, pathologic review, gene expression, and protein expression. And really, they were able to group melanomas into 4 subtypes. So your BRAF mutated tumors, which tend to occur in younger patients, with intermittently sun-exposed skin. They can also have MITF amplifications. Your RAS, which we know is typically NRAS mutated tumors, which have high MAP kinase activation. They can overexpress AKT3. NF1 mutated tumors typically occur in older patients and are known to have a high mutational burden. And then your wild type. So now we're thinking kind of like triple negative, as would be the equivalent in breast cancer, which lacks a UV signature, and they have a lot of complex rearrangements in their chromosomes. Now, they looked at immune signatures, and they found that a high lymphocytic infiltrate was associated with improved survival. That's been shown many times by many groups, such as here. And basically, there are clinical management implications. So BRAF inhibitors are applicable for BRAF mutated tumors, other types of MAP kinase inhibitors for NRAS, and so on and so forth. And that's shown here. So in general, melanoma has mitogen activated protein kinase or MAP kinase pathway addiction. And this occurs via mutations along various channels. So this would be an NRAS mutation, BRAF mutation, NF1 mutation would result in a lack of inhibition of MAP kinase, and things like Ckit through tyrosine receptor kinases would activate still MAP kinase through this pathway. And so we've got BRAF inhibitors and MEK inhibitors, which act here. BRAF inhibitors act here. MEK inhibitors act here. And the reason being is that we know that most patients will develop BRAF resistance relatively shortly. And the mechanism of this resistance is not due to a second site mutation in BRAF as much as reactivation of the MAP kinase pathway. And that can occur through independent MEK activation. So we almost always will combine these two drugs together. We also see non-BRAF V600E mutations, and those can result from fusions. They're not sensitive to BRAF inhibitors, but maybe to MEK inhibitors. There are drugs which are looking at usage in NRAS mutated tumors, drugs applicable to Ckit mutated tumors. And the point really here is, what does this mean for pathology? So we do reflex molecular testing on all stage 3 and above patients, or any patients that are less advanced and our clinicians request molecular testing. And the algorithm we have is that for stage 3 and above, we'll do BRAF V600E immunohistochemistry on either a lymph node, a metastasis. If those don't have enough tumor bulk, we'll go ahead and look at the primary tumor. And if there's greater than 95% of tumor cells positive, we call it positive for BRAF V600E. We know the drugs they're going to use. We don't necessarily do multiplex next-gen sequencing unless it's requested. If there is heterogeneous staining, so 5 to 95%, or negative staining, we'll reflex to next-generation sequencing. And we'll either find BRAF, NRAS, Ckit, or no mutations, and we'll report those out accordingly. So here's an example of somewhat moderately pigmented melanoma that was negative for BRAF V600E immunohistochemistry. You do see staining here, but it's actually the melanin pigment. And you can figure that out by comparing it to the control. Here was a case from a metastatic biopsy, which was heterogeneous for BRAF V600E, as you can see here. Partial staining, probably about 75% staining. Here's a case that was positive, homogeneous for BRAF V600E, so we would not order next-gen sequencing on this case out of the 3, unless it was specifically requested. The way that we set up our protocol is really based off the study at MD Anderson. They use the iron torrent for their next-gen sequencing, which is the same one that we're using currently, and they use Ventana with this spring antibody, which is the one we use. And they defined positive heterogeneous as any cells, but not up to 95%. Homogeneous positive greater or equal to 95%. Negative is no cells. Now you can only count cytoplasmic or membranous staining, not nuclear staining. So here's an example of positive, homogeneous positive staining from their study. This is an example of heterogeneous positive. You have a few cells that are positive on the membrane and some that are negative. And this was negative. This was actually nuclear staining, which doesn't count. So in their study, they had 154 cases. About 36 of them were homogeneous or heterogeneous positive, and 75% of those were positive for BRAF mutation by next-gen sequencing. 53 of those 56 had a BRAF V600E mutation by next-gen sequencing. It was 71% of all seen. The sensitivity was 85% if they only included homogeneous positive, and it went up to 98% if they included homogeneous and heterogeneous. So that's why we reflex heterogeneous to next-gen sequencing. But the sensitivity and specificity overall is pretty high with this antibody. They had one single false negative, which is what we want to avoid with the screening test, and that was due to, they called it negative because of all the pigment. They couldn't actually see that there was positive staining because it was obscured by the pigment. So that's a pitfall. Now, even though BRAF V600E mutation is kind of the sentinel predictive biomarker for molecular therapy, it's my impression that we're going to be needing biomarkers on every case where systemic treatment is considered. And it might be a broader panel of biomarkers, because this study really highlights that when you look across all tumor types, over 75% of sequenced tumors had alterations in genes where there are currently existing drugs that target those genes or drugs in clinical trial. And here's melanoma. It was 90% of the cases had some kind of targetable mutation. This is the panel that we're currently using in our pathology department. It has 50 genes that it looks at mutations for. We report on BRAF, Ckit, and NRAS. Right now we don't report on NF1 because the gene is simply too big. At the end of this year, we'll be bringing on an Illumina panel with 170 genes, and that does include NF1 mutation among several others. And so, switching gears to the next category of targeted therapy, it's immune-targeted therapy. So in addition to IL-2, we also now have options to inhibit CTLA-4 at the T-cell priming phase with ipilimumab and PD-1, PD-L1 interactions at the T-cell effector phase with various drugs, and even oncolytic virus therapy. There was a hope, really, that PD-L1 expression in melanoma tumors would be the next biomarker, the immune-targeted biomarker. And here we can see that PD-L1 expression is typically regional in tumors. It typically is seen in the area of lymphocytic inflammation because it's thought to be brought on by that interferon gamma produced by T cells. So this would be a positive case. Here we have absent expression, and then here is diffuse expression, which in the absence of inflammation can actually sometimes occur due to a mutation in the tumor itself, which upregulates PD-L1. Only membranous tumor staining is considered positive. Depending on the clone that you use, 1% of tumor cells positive or 5% of tumor cells positive can be considered positive in a given tumor. We simply report the percentage of positive when it's asked of us, and then we let them do with the information what they want. So when does it matter? So patients who have PD-L1 positive tumors will respond similarly to Nivo as to Ipi and Nivo. So really, Ipi and Nivo has more toxicity. You usually give that unless they're frail, in which case you might want to give Pembro alone, and you might want to know the PD-L1 expression. And this is kind of shown in here. The confusion, I think, will be outlined in the following studies. So the first study looking at PD-L1 inhibition was with nivolumab. There was a 28% response rate in melanomas. When they looked at correlation with PD-L1 staining, they found that in patients who had negative staining, which was less than 5% membranous staining when 100 tumor cells were available, none of them responded to treatment. So all of your responders, which are here, were in that PD-L1 positive category. Now, follow-up studies have been published. Here's one with nivolumab. They had a 40% response rate. And here, PD-L1 IHC was not predictive of response as compared to the other study. Here was another trial looking at Nivo with Ipi combined, 38% response rate. They considered 5% or greater to be positive. PD-L1 staining or absolute lymphocyte count at baseline was not predictive of response. So it really hasn't panned out the way that BRAF immunohistochemical staining has. Here's looking at pembrolizumab. What's pembrolizumab now? They saw a 53% response rate. Some patients had post-treatment biopsies where they showed infiltration of CD8 positive T cells, just reaffirming the mechanism of action here. They didn't mention biomarkers. They didn't mention PD-L1 expression, so I would assume that it wasn't predictive of response. And so in summary, while PD-L1 staining does correlate with response to either single agent nivolumab or pembrolizumab, it's an imperfect correlation. And just because you have negativity with PD-L1 IHC, it doesn't rule out that a patient could have a response. So it's predictive of response, but it's not as sensitive as a marker as we would like. Negative PD-L1 expression may indicate a need for combination treatment. So you can't just treat with Nivo or Pembro as a single agent. You may consider adding CTLA-4 inhibition or viral oncolytic therapy. And so just to go over what we've talked today, IHC is important in diagnosing melanoma at the start. If there's worrisome IHC patterns, it would indicate that molecular tests should be done. Those will be discussed later. In the setting of sentinel lymph node biopsy, it's an aid to bring out isolated tumor cells that would otherwise be missed on H&E stainings. We use a panel of 3 markers. I think that's the best way to do it. Systemic management, we can look at molecular targeted therapy where BRAF IHC is a good sensitive screening test for BRAF V600E mutation, reflex to molecular test in negative or heterogeneous cases. And then PD-L1 staining is not quite where we'd want it to be to select patients for immunotherapy, which is a more sort of less well understood response and mechanism. I think future immunohistochemical tests will be developed with molecular guidance for other types of mutations that will become more and more targeted in the setting of melanoma.